everybody knows Steve. He's our policy work group leader. He's just amazing resource and person based out of Hawaii. Did you get any waves in today, or is it too early?
Too early.
All right. Well, welcome, Steve. Thanks for coming in to talk about global budgets for hospitals. Welcome. Thank you.
Okay. All right. Let's just get started. Okay. The purpose and definition of global budgets for hospitals is confused. CMS equates global budgeting with capitation and financial incentives. The problem is fee-for-service causing excessive care, and capitation or a fixed payment per person per year would reverse this incentive and reward restricting care. And CMS tries to insert financial incentives to reduce costs and meet quality metrics. And they are pushing toward capitation or payment per member, which requires defined members, which is a problem in traditional Medicare. And they welcome fiscal intermediaries, many of which are for-profit. In contrast, Canada and Scotland see global budgeting as the most cost-effective way to pay hospitals what they need to deliver the services their community needs, which is a very different concept behind the idea of global budgeting. Okay. CMS is locked into a false rationale that to control costs, we must move away from fee-for-service with its volume incentives and replace it with value-based payment, shifting insurance risk onto providers of care, paying them upfront via capitation and bundle payments, opportunity to keep more money by delivering less care. They say that we can eliminate fragmentation, improve quality by organizing doctors and hospitals into accountable care organizations that can accept insurance risk. But who are such organizations accountable to? Beneficiaries and patients, or CMS, or to investors and shareholders? But overutilization is not the real problem. US doctor visits and hospital days per capita are among the lowest among industrialized countries, according to OECD data. Inadequate access to appropriate care driving costly complications is a far greater problem than unnecessary care due to fee-for-service. And excessive administrative costs driving much higher prices is the biggest cost driver, followed by exorbitant drug prices. So the real problem is high administrative costs, not volume of care. And I think we need to look at different ways of doing global budgeting from the point of view is what is the administrative overhead of that method? Because that's where the problem is. So CMS thinks of global budgets as part of value-based payment and shifting insurance risk onto doctors and hospitals, and they are not paying attention to administrative costs. They keep piling on more administrative costs without removing the existing costs, and this is just making things worse. They rely on financial incentives and risk shifting to induce hospitals to restrict care and finance moving more care to less expensive settings. They use pay-for-quality incentives, and their eventual goal is capitation and full risk contracting with systems of doctors and hospitals, not minimizing administrative costs. So capitation or payment per member requires members, and this leads to perverse incentives. The financial performance of a capitated entity depends more on which members that organization has than on anything they do to try to improve quality or cost effectiveness of care. This means they have a strong incentive to game their risk pool, secure healthier than average population of members by cherry picking and lemon dropping, or getting paid as if the members had average health risk and profiting from the difference. CMS tries to correct this with risk adjustment, which is very inaccurate at predicting individual risk, and it fails to deter cherry picking and lemon dropping, such as within a diagnostic category. And it ties payment to diagnosis. This is a result of risk adjustment. It ties payment to diagnosis, creating the incentive to upcode diagnoses to game the risk adjustment formula. So why is CMS trying to introduce financial incentives to get doctors and hospitals to deliver high quality care? Were they not motivated to do so prior to pay-for-performance and value-based payment? And do insurance companies know better how to manage care than doctors and hospitals? And what about all the time-consuming and unnecessary administrative obstacles to quality of care and care coordination that are being imposed now with detailed documentation and coding requirements for payment, multiple plans of different networks, different payment policies and fees, different claims denial policies, different formularies, different prior authorizations, et cetera. These take up half of a doctor's time in the day or more. So what's the difference between capitation and budgets? Capitation conveys insurance risk. A fixed payment per member with an obligation to cover specified services over a specified period of time means there's an opportunity to keep unspent earnings as profit or risk of loss if more is spent than capitated payment. And capitation welcomes for-profit intermediaries and profiteers, and it introduces incentives to skimp on care, game the risk pool, and upcode. Global budgeting of hospitals, according to what I consider to be the best definition, does not convey insurance risk. There would be no members. And the hospitals, or you could also have a hospital and a physician group as an integrated entity like Kaiser without its insurance functions and membership, could offer care available, make care available to all who need it. A budget is based on the cost of operations, not an opportunity for profit or loss. It can be adjusted with changing circumstances. Budgeting, global operating budgets do not allow retained earnings. Surplus goes to the next year's operating budget and losses are covered by supplemental appropriations. So there's no shifting of insurance risk with a global operating budget. So definitions, global budgets can mean different things. And there are three broad categories of what global budgets mean. The first is fixed prepayment based on the cost of operations. And this is not intended as a financial incentive, is not intended as an opportunity for profit or loss. And examples are funding of fire departments, police departments, schools, etc. Capitation is a fixed prepayment per capita or per member, which requires the system to assign members. It shifts insurance risk onto providers. It creates an opportunity for profit or loss. It's vulnerable to gaming, and it invites profiteers. So capitation is not the same as budgeting. Price adjustment is a system in which payment to providers still uses fee for service, but then adjust prices in accordance with volume so as to meet a predetermined fixed budget goal at the end of the year. So it requires the infrastructure of fee for service with a reconciliation at the end of the year to meet a budget. This is the way they do it in Taiwan, some Canadian provinces, and the German ambulatory sector. So global budgeting of hospitals in Canada and Scotland, and also in Jayapal's HR in 1976. They pay hospitals a global operating budget, which is type 1 budgeting, fixed prepayment per year based on cost of operations. They have separate grants for capital needs, such as new buildings and expensive new equipment. This eliminates hospital billing and collection costs, which are around 15% of a hospital budget in the US. Hospital administrative costs in 2014, US was 25.3% and rising, Canada 12.42, Scotland 11.59. So let's look at Maryland. From the 1970s to 2013, they used all payer rate setting with fee for service. In other words, all payers in the state had to pay hospitals the same rates for the same services. This stabilized hospital payment and eliminated cost shifting among insurers. It spread the burden of the uninsured and postgraduate medical education training across all payers. But because Medicare had been paying lower than average rates, when they now had to pay average rates, it resulted in higher Medicare fees than in other states. And it achieved minimal reduction in billing insurance-related costs because it still relies on fee-for-service infrastructure. So from 2014 to 2017, Maryland moved to global budget revenue, which is all payer rate setting plus global budgets using fee-for-service billing reconciled to the budget, which is type 3 budgeting, plus pay for performance. This is applied to hospitals only, and it resulted in some slowing in hospital spending, but Maryland was still among the most expensive states for Medicare because they were paying higher than average rates. So from 2018 and plan through 2024, they moved to total cost of care budgeting, which applies to both hospital and non-hospital settings spending. And this involves partial capitation via members who are attributed by where they seek care. It still uses fee-for-service claims reconciled to an end-of-the-year budget, which is type 3 budgeting. So it's a mix of type 2 and 3, capitation and retrospective reconciliation to a budget, and adjusted for capitation. In other words, any money that flows through capitation gets deducted from the fee-for-service fees and then pay for performance incentives. This relies on many adjustments to hospital budgets, complex risk shifting, capitation, pay for performance incentives, plus submission of fee-for-service claims. So it has high administrative costs, and the net effect on total cost is yet to be determined. Pennsylvania Rural Health Model. Pennsylvania has several payers, including Medicare, Medicaid, and some commercial payers that pool funds to pay hospitals with global budgets. Not all payers participate, and the model is type 3 budgeting, requiring fee-for-service claims reconciled to a budget at the end of the year, so the hospitals must maintain their billing and collections infrastructure. The program adds pay for performance incentives for hospitals to divert funds to non-hospital services, such as community programs for substance abuse and high-risk patients. And the goals are to improve access to non-hospital care, shift more of care to outside the hospital to reduce hospital costs, reduce rural health disparities, and reduce deaths from substance abuse, and improve care for opioid abuse. This relies, again, on type 3 budgeting, resting on a fee-for-service infrastructure that's reconciled at the end of the year to the budget goal. And it does stabilize funding for the hospitals, but there's not much in the way of administrative savings. The Vermont all-payer ACO model. This is very complex. It requires hospitals to track and submit fee-for-service claims and reconcile them to a capitated budget, which is a mix of type 2 and 3 budgeting. It combines OneCare Vermont ACO with Medicaid 1115 waiver, with capitation via attributed membership, depending on where people seek care, and lots of pay for performance incentives. Their goal was to get 70% of all Vermont insured residents and 90% of Medicare beneficiaries in the ACO. They had all payer and Medicare financial targets and health outcomes and quality of care targets, all of which were wrapped into the model. So NORC at U of Chicago did an independent evaluation and reported on this in August 2021. And they found that the program did not meet their participation goals. Only 8 of the 15 hospitals in the OneCare network participated in the Vermont all-payer ACO payment initiatives, and participation was particularly low for critical access hospitals, with only 2 out of 8 participating. And hospital administrators voiced frustration about the continued need to submit and track fee-for-service claims when they were supposed to be paid with a global budget. There are no administrative savings at all in this arrangement. So although the all-payer ACO did achieve some reductions in hospital utilization, non-ACO hospitals achieved even greater reductions. So the reductions may have been in spite of the ACO model, not because of it. And limited hospital and physician participation also limited interpretability of financial results, as there were shifts by patients from ACO to non-ACO practices, and those tended to be sicker patients. So it could be that the ACO patients ended up with a healthier risk pool than the non-ACO patients, and that could explain any apparent savings. So how can hospital budgets achieve cost effectiveness? The first thing is to focus on reducing administrative costs, not incentives to reduce utilization. So we would want to pool hospital funds from all payer. It's simplest with a single payer, but even with multiple payers, if you pool hospital funds from all payers in proportion to the hospital needs of each plan's population, and pay hospitals with a global operating budget based on the cost of operations, not risk shifting, this would eliminate billing and collections. It would eliminate fee-for-service completely. It would eliminate cost shifting among plans and charge master gains. There'd be no allowed profits or retained earnings at the end of the year, and capital expenditures should be paid with a separate fund allocated according to community need. It's essential to eliminate fiscal intermediaries. The state must pay providers of care directly with no fiscal intermediaries. This means the state retains insurance risk and covers any ups and downs of care costs year to year from a reserve fund. Necessary administration can be contracted to an administrative services only contractor on a non-risk basis. So this non-risk ASO can handle claims processing, credentialing, administrative support for care coordination programs, quality improvement, and customer service and things like that. So as an example of this, consider what Connecticut Medicaid did. They had full risk managed care organizations in place for a decade. And in 2012, based on a lot of publicity of how the plans were gaming payment, hiding their data, raising costs, including a rise of 45% in costs over the 4-year period, 2008 to 2012, the state terminated the managed care program. They took back insurance risk and self-insured Medicaid, and they provide enhanced funding and support for primary care. And this is called enhanced primary care case management. So they let their primary care doctors manage care instead of an insurance company. They contracted necessary administration to an ASO contractor on a non-risk basis using a former local managed care plan that was willing to switch to just administrative services and no risk. In 2018, which is 6 years later, physician acceptance of medication was up substantially, around 30%. ER usage had dropped 25%, and hospital admissions and readmissions were down 6%. In 2018, per member Medicaid costs were coming in 14% lower than in 2012, 6 years earlier. So over a 6-year period, their total cost dropped 14%. After 6 years, it started going up again, but at a much slower rate than it had been going before. And in 2020, their Medicaid administrative costs were 2.8%, including the administrative services only contract, compared to 15 to 40% for Medicaid managed care and 12.5% for Connecticut commercial plans. Much lower administrative costs. So what we want is, if you're going to have multiple payers, you want to have them pool the funds for hospital payment, use type 1 global budgets with no risk shifting, have the state take on insurance risk, and eliminate billing and collections for hospitals. You can have an option to allow a physician group practice to join a nearby hospital with a combined global operating budget. This is like Kaiser, but without members and without insurance functions. And you pay for capital expenditures separately according to community need. The goals are to minimize hospital administrative costs, eliminate cost shifting and charge master games, minimize opportunities for billing fraud and abuse. With global budgeting of hospitals, there's no incentive for unnecessary care and no risk pools, no risk adjustment, and no upcoding. It provides predictability and stability for hospital budgets, and it would rescue rural and critical access hospitals. So I'm open for questions.
That's quite a mouthful there, Steve. Really excellent presentation. The first thing to ask is, are these slides available for people to review?
Yeah, I can put it in the chat right now. I pretty much read the slides. Everything is in there.
Yeah. No, very, very powerful. I mean, especially the back end where you get to the distillation of solutions. So we do have hands up in the room, and I just want to reset because I think about 8 or 10 people joined since we started. You're on a One Pair States call. I'm Chuck Pinocchio, president of One Pair States, and our presenter today is Steve Kemble, who's chair of our policy work group. The topic is global budgeting for hospitals. How do we get our arms around this issue? So Lynn Cheney, you want to come up with a question?
Yeah, Steve, the Medicare funds at the state level, what's the best way to bring those in to create that single pool for the hospitals?
Well, you need to persuade CMS to, instead of trying to budget hospitals with some form of capitation and reconcile fee for service, to calculate the hospital needs of the Medicare population and provide that money as a lump sum to the state to contribute to the budgeting of the hospitals, and do the same with Medicaid and with commercial insurers. You get the money into a state fund, the state then pays the hospitals with a global budget based on the cost of operations. But you would need Medicare to, and all payers, to calculate the hospital needs of their population, boil that down to a lump sum, and give it to the state for a fund to fund hospitals.
And
That's
for the
right.
individual who's insured, what does that look like when you've got some people under traditional Medicare Advantages, et cetera? They just go to the hospital and it gets taken care of?
Exactly. The hospital is prepaid. It doesn't matter what insurance you have. The hospital's budget is covered, and they'll just take care of whatever comes in their door
Okay,
without any need to bill. There's no, I mean, the connection between hospital services and having to bill somebody has been severed.
mhm.
All good, Lynn?
Yep.
Great, thank you. And thanks, Steve. Charlie Swanson from Oregon. Hey, Charlie.
Hey, so Steve, let's see, who would we talk to? We as in a state entity that's trying to devise a single payer system. Who would we talk to in, say, Canada, who would know about the details of how these budgets can be set? Either somebody, well, preferably somebody if within a Canadian hospital, administrative portion, and also within a province's budgeting, authority piece that gets money out. Because it would be really nice if state planning people could talk with somebody who has used this sort of a system, both for the paying end and the hospital end.
I think talking to Canadian hospitals that do budgeting this way would be a very helpful step to take. The other avenue would be to ask the hospitals for their detailed financial data, deduct the cost of billing and collections, look at it in terms of what does it cost to, pay you the salaries of everyone that works in your hospital, what does it cost to run your plant, all those kind of things, add those up and then negotiate from there. But looking at the experience of Canada would be very helpful.
And so very closely related to that, you said that some provinces use something other than option one. I think you said they might use option three. Do you know which one? Option one?
They use fee for service and reconcile it to a budget. Apparently that's true in some places in Canada. I don't know any details about that.
Okay, thanks.
Just as a footnote, I know that California legislator Ash Kara traveled to Toronto prior to introducing his bill, AB 1400. It might be interesting to reach out to him and see what he had to learn. Let's see, Barbara Pearson from Massachusetts. Barbara.
Just as a
Yeah.
response, AB 1400 does budget hospitals in the way that I'm recommending, but the problem is, how do you calculate the cost of operations to determine the hospital's budget? And it doesn't answer that question.
Good catch, Steve. Thank you. Barbara?
Yeah, so thank you, Steve. Thank you. I've been trying to dream about rural areas doing a Connecticut so that they would, they have so many failing situations there, and they have so many of the commercial entities that have withdrawn, although we do know about private equity going in there. But who would ask for what? Is it done at the state level? Who would have to be organized to try and make this happen?
I think.
Does it have to be for this whole state? Could it be just the rural area?
It could be just for rural areas, or it could be for the whole state. I think it would happen at the state level. But again, you have to get whatever your funding sources are to separate out hospital costs, pool them, and allow the state to pay the hospitals with the budget without any billing and collections.
Well, I would love to have it happen. I'm still not quite sure who to tell what to do what,
By
but
the
I
way,
mean, it's not something that,
there's something for there's something in the way this Zoom is set up that I cannot post the slides. So if you can either change it so I can do that, or else send me an email list of the participants so I can share the slides with everyone, but I'm unable to put the file into the chat.
Mike? You're muted. Any thoughts?
I'll work on it.
could
Um,
did I
go
finish my
ahead.
turn?
Go ahead.
I just wondered, CMS is already doing a whole bunch of stuff for rural areas, and I don't know to what extent that goes through the state. Because it happens, I think, even in states, for example, that don't take Medicaid.
Well, with Pennsylvania, they've taken Medicare, Medicaid, and some commercial plans, and they have had them all agree to pay hospitals with global budgeting using type 3 budgeting. So it's on a fee-for-service chassis, but it's adjusted so that they end up being paid the same by all payers, and they end up with a global budget. And that's helpful.
You didn't recommend it,
What?
but you didn't recommend that model.
Well, I think this is halfway measure. It doesn't achieve all the administrative savings that eliminating billing and collections would achieve, but it does make the payment much fairer and more consistent, and it would enable survival of rural hospitals. And this
Okay.
is specifically for rural hospitals in Pennsylvania.
Thank you.
Okay, Barbara. Let's see, Rich Shannon from Colorado. Rich?
Yes, thanks for the topic today. I may have missed it if you already covered this, but I appreciate either repeating or expanding a little more on the difference between the methodology for calculating a global budget in a rural environment versus one in urban. And the little bit I've read about this, to use an example, is that in a rural setting, you would identify a base amount of funding in order to have, say, a maternity facility, regardless of number of people utilizing it, so that people aren't having to drive 100 miles for delivery. Whereas in an urban setting, it may be more a function of volume of different kinds of services. Can you help clarify that?
Well, one of the problems with trying to deal with rural hospitals the way CMS is doing it is it relies on benchmarks and their track record of fee-for-service billings and trying to adjust that and things like that. If you did it this way based on the cost of operations, all those things would go away. You wouldn't have to look at their fee-for-service records. You just need to look at what it costs for them to run their hospital and provide the services the community needs. And you negotiate what that price should be. You use their actual figures for cost of operations, and you negotiate your price and you pay them that amount per year, and you eliminate billing and collections. Does that answer your question?
No, I'm still confused, I think. Let's use the maternity ward again.
Yeah.
If they have, in a rural setting, if they have 100 deliveries a year, or say 50 deliveries a year, and you develop what the fee for service would be for that, it doesn't add up to the cost it would take to have all the proper facilities there for a maternity ward.
Right.
And maybe maternity is the poor example. So
Yeah.
that
So you don't rely on the record of fee-for-service billings. You look at what does it cost to run your hospital? What does it cost to hire your obstetricians and anesthesiologists and ER doctors and whoever's employed by the hospital? You add up those costs and you pay the hospital a budget based on those costs, and you eliminate fee-for-service billing. And the track record of fee-for-service is not used as a benchmark. It's the cost of operations that you're trying to calculate the budget from.
Thank you.
All right, Rich, thank you. And Steve, thank you. Corinne, where are you from? You're
I'm
muted.
from Humboldt County, California, which is a rural county that has a few small hospitals. I think one of the last family-owned hospital, but then it's competing with Providence Hospital in the nearby town. What I'm wondering is there are still doctors that see their own patients in the hospitals. How would they be paid? And also California has scope of practice, which means the hospitals can't directly employ doctors.
That's fine. Those doctors would get paid fee for service.
Okay. All right.
I think the way CMS does fee for service could be improved too substantially, but that's another subject.
Thank you.
All right, thanks, Corinne, Steve. Jan, and where are you from?
I'm from Durango, Colorado, a very rural area of Colorado, and I'm very interested in this presentation, but unfortunately, I was not able to grasp all of what you were saying, and I have a few questions. One is in Pennsylvania, I believe they were one of 5 states that were going to be an experimental program with global budgeting in rural areas, and the 4 other states couldn't get enough hospitals together. And I'm wondering, what is the limit? We have 4 hospitals within an hour, and then that's it for quite a while. Would we have to have more hospitals to be able to try out a global budgeting form in our area?
I don't think so. It seems to me this could be done even with 1 hospital, but it requires getting the different payers to pool the money for hospitals. And that's probably easier done on a broader basis than just for a single hospital. You know, if they can take their population and say, how much are we spending on hospital care, and deduct the cost of billing and collections and give that to the hospital as a lump sum, and all payers participate, they're going to have an easier time doing that if they include all the hospitals in the area than if they try to sort out which of their patients went to which hospital. So it would be easier to do it if you include all the hospitals in an area.
Right.
Then you don't have to worry about who went to which hospital.
They've been so competitive with each other for so long, and are all bleeding providers at this point too. You know, they just keep going from one to the other, and nobody has good access. We have quite a problem with physician deficit and specialist deficit in our areas. So I've been looking at this concept for a long time, and I think I saw somewhere in your slides what would be better to propose, because I've talked with people who are administrators in hospitals, and they say, no, you know, that won't work here. And I don't have the nitty gritties to understand why. So perhaps if we do get a copy of your slides, I could read through that slowly again and figure it out. But it's a huge problem. And then what do you do about Catholic hospital systems that we're in the middle of having a little tiff about with maternity services, and not wanting to lose all of that? So I'm sorry, this is big and a lot, but perhaps if we could contact you outside of this webinar, it would be helpful. But thank you so much for all the work you've done.
You're welcome. In Pennsylvania, they didn't get all the commercial payers to participate, but they got several of them in addition to all of Medicare and Medicaid. So that was a pretty big chunk of the playing field that were captured by the model. But as I said, it doesn't have nearly the administrative savings it could have, because it still relies on a fee-for-service infrastructure that's reconciled at the end of the year. So they still have to do all the same fee-for-service billing.
Okay. Steve, have
Hank,
you? I'm sorry, I was
Hank
gonna.
on Maine.
Go ahead.
Just put Hank from Maine in the queue. Thank you.
Okay, didn't see your hands up in the queue. All right, we got Gene Hopkins up. And Steve, before Gene comes up, what is the best way to contact you for folks?
Just a sec.
Actually, Hank is on the phone, so you won't see a hand, but let me know when available. Thank you.
Okay, you'll come up after Gene, Hank.
I'll put in my email address.
And then, Mike, would it make sense for people who want to get a copy of the slides to, if folks are registered, I guess we could just do it automatically off of that, or would you rather people directly contact you or drop their contact info in the chat? What's easiest?
I'll send it to all the registrants. In
Yeah.
fact, all of one pair states.
Okay, I can, it would take me a couple minutes, but I could go back to my Dropbox, create a link and put that in the chat, but I have to get out of this screen and into that screen and then come back again to do that.
Okay, we'll figure all things out. We still have a little bit of time and the queue isn't too piled up right now. So let's bring up Jean Hopkins and then,
Hi, I know Steve mentioned Vermont and, you know, the University of Vermont Medical Center has been sort of becoming the one big force in the state. Even New York's people fly over the lake to come here. But an accountable care organization called One Care Vermont. You might want to look it up. Supposedly the University of Vermont was with it, and maybe the parent organization, what I just read. But I read in the news recently that the UVM Medical Center wanted to separate from One Care. So now I'm searching for that, that article and can't find it. But I think it is because, as Steve said, that it's a complicated system. So
That One Care is the only ACO for all of Vermont. So that was the
Yeah.
idea, to set it up as one big ACO, but they haven't been able to get consistent participation. As you say, those who do participate have a lot of administrative burdens and end up being unhappy with the model, and then they leave.
Yeah.
So it's been unstable.
yeah. Thank you. Okay.
okay, Jean. And then we're going to bring up Hank, who's with us by phone. Hank from Vermont, from Maine. Sorry, Hank.
Great, thank you. Sorry for the road noise. Great presentation, especially interested in the Connecticut Medicaid example, because that seems to have shown, quote, demonstrable success, unquote, as opposed to all of the other ACO things we've reviewed over time have no net benefit or 0.1% saving or 0.1% over non-savings or no savings demonstrated. So interested in the Connecticut Medicaid change. And Steve, again, if you can also source us or give us the idea where you got that information from, so that we
Sure,
can just.
I've got a lot on that I'd be happy to send along with the slides.
Thank you so much. Thanks. I'm done.
Okay, Hank. Yeah, so Steve, you'll send out your bibliography, essentially your research sources.
Yeah, I'll send the slides, and I can have a couple of files for the Connecticut Medicaid program that I can send along with it.
And I see Bill's hand. Are you planning to publish what you've presented today in some form?
I haven't gotten anywhere close to that. It's something that might be a project for, we've already written a paper on paying hospitals the global budgets for the one payer states policy working group that's on the OPS website. So we already have that, but it's not the same as this presentation. But the recommendation is the same.
Okay, thanks, Steve. Bill Semple from Colorado, Boulder, in fact.
Yeah, thanks, Chuck. Steve, thanks for the presentation. Wondering, I'm impressed by the ability of hospitals to probably continue to game things as much as they can. If one hospital were paying twice as much to its employees as another hospital, same county, how would you get to a fair global budget between the two hospitals?
Well, the way I imagine that working is if the state is negotiating budgets with all the hospitals in the area, they would soon figure out, because they're looking at this at each hospital's data on their cost of operations, they would soon see that one hospital is paying their employees very differently from the others, and they would seek to standardize that. So that would come from the state being able to look at all the hospitals' budgets at the same time and compare them.
Okay.
Okay, thanks, Bill.
Hank has a comment. In researching Canada, it seems the nurses in the Canadian provinces negotiate their wages with the province, not with the hospitals.
Yeah.
Interesting fact that might normalize wages for the nurses in that regard.
And it makes it very easy to calculate the nursing part of the hospital's budget too.
Okay, thanks, Hank. Lydia from Colorado. Hey, Lydia.
Yes, thank you. The presentation was awesome. So thank you for your work. And I will look at the website for that article, but I have a question around states who are writing or pushing for bills for single payer. What do you recommend? Do you recommend they include global budgeting as one of the essentials in the language?
Absolutely. Absolutely. I think it's essential. And if you do global budgeting of hospitals the way that I'm recommending based on cost of operations, it eliminates the insurance function of organizations like Kaiser. You can preserve the hospital physician integrated organization, but there would be no members and there would be no capitation because you can't capitate without members. And if there's no members, you're paying the hospital based on the cost of their operations. So you can preserve the doctor hospital part of Kaiser and strip it of its insurance functions that way. And if you budget hospitals with global operating budgets, you're basically pushing the insurance industry out of the state.
Thank you.
Thanks, Lydia. I have anybody else have a hand up? I have a question if not, and that is one of the critiques of Canada is that with their global budgeting, they often fall short in terms of resources for non-essential care toward the end of the year. But why? Can you explain why that is, Steve? And just in terms of projecting costs year in and year out, and how do you build in costs for unanticipated crises like a pandemic?
Okay, the first part of that is that I think this is actually a problem in general with single payer systems, is that they tend to get underfunded over time because nobody wants to raise taxes. And the best protection against underfunding is regular renegotiations. And so you have to empower the professional organizations, doctors and nurses, to negotiate with the single payer. You have to, or with the state, you have to empower hospitals to negotiate with the state so that there's some balance between their interests and the interests of the state to minimize funding. If you just allow the state to unilaterally set prices, you're going to get underfunding almost for sure. What was the rest of your question?
So that was the budgeting piece. I'm running short on fumes here.
Pandemic.
Right. Unanticipated issues. Right. Thank you.
Unanticipated issues. If the pandemic actually resulted in reduced utilization overall, there are more ICU usage and less of everything else. And overall, there was less utilization. So it didn't actually harm the insurance companies. It harmed the doctors in the hospitals. But the way you would deal with a pandemic that did cost more would be you would ask this funding source, the state or the federal government, for a supplemental appropriation, or you would make it up in the next year's budget. This in Hawaii, before they turned Medicaid over to managed care, the state funded Medicaid with fee-for-service payment directly to providers. And every year they would make a budget and plan on how much they thought it would cost to fund Medicaid. And then they would run out of money 10.5 months into the year. And for the last 6 weeks of the fiscal year, nobody got paid. And then they would renegotiate the budget for the next year. They would build in the back payments from the previous year and raise the amount for the next year. And this is a hassle for the legislature. It's why they were open to the idea of Medicaid managed care. But even though Medicaid managed care gave them a fixed budget for the year, it also put them at the mercy of the managed care companies, so they could demand whatever raise they wanted every year, and it didn't actually save them any money. It cost them more. But that's how you would deal with unexpected. You have to have a supplemental budget or make it up in the next year's budget.
Okay, very helpful. And I saw Mike and Charlie's hands are up. I do want to point folks to the chat before you cut out. We want folks to, if you're if at all possible, come join us tomorrow for our intergenerational summit, our third summit. We put so much work into this, and especially spread the word among younger folks in your cohort. Really, it's a very powerful thing. I'll talk about it more on the very back end for folks. But please do spread the word. This is really important work for building our strategy to win. We've got to connect all of our social justice movements and build alliance with younger people, communities of color, all classes, genders, and so forth. So that's the work that we're doing tomorrow, 12 to 2 Eastern time, 9 to 11 Pacific. Really, this is our third one. We pour a lot into this. We really appreciate the support. Thank you so much. Mike?
Yes, in the next hour, 4 of us will be meeting with the CEO of a 5-hospital chain here in Corvallis, Benton County area. My temptation is to send the recording and play it for him tomorrow in the next hour. But I want a logical way to talk with hospital administrators about what you've just told us. I'm afraid we would frighten him away if we presented the whole thing to him.
Well, if the hospital is given a budget that's adequate to cover their cost of operations, and it doesn't matter what their utilization is, they don't have to pay for billing and collections, they have their budget, they can run their operations. I don't see that as being that scary for a hospital administrator. Maybe it could be framed to be scary by those who have a vested interest in the status quo, but it basically means your funding is secure and you can run your operations and you can deliver the services you need to deliver, and you know the money is there.
Thanks. Yeah, we'll try.
Okay, Mike, you're done? Okay. Any other questions from the group?
Catherine?
Yeah, I have a question. Because I'm up here by the Canadian border, not too far from it, so I often run into Canadians here. One of the things that they mentioned to me was that they're really hopeful that we would get like an expanded and improved Medicare for all, because currently right now, they just have hospital and physician office coverage. They don't have coverage for like, they have to buy additional insurance coverage for vision,
Drugs.
all that stuff.
Yeah.
And so they're hoping that if we encompass that that would encourage their country to do the same thing. But I've been always wondering, what can we do? And I really like, and I agree with what you said on that we could go ahead and kind of guarantee or make a promise to the insurance companies that they can do the administrative services. In fact, one insurance company worker, she signed it because she said, we want this to pass her as a worker because we'll still have the work, because we know we'll still be running all the billing. But I kind of think that maybe we could possibly, what could we throw at them to be able to cover? Well, I think we could throw at them, coverage for when you go out of country. Somebody asked me that once, will the Washington Health Trust cover me if I go out of country? It's like, maybe that's something we could make the insurance companies pay extra for. And the other thing is, maybe we can make people pay a little extra for if they need to get airlifted out. Like I used to try to do a 100-mile ride in the California Sierra Nevadas, and I paid, $20 for an additional policy that would cover me if I had to get airlifted out, me or my horse.
Well, I think with regard to that a properly designed single payer system or all payer with global budgeting of hospitals or whatever would need to include all medically necessary services. Otherwise, you're going to get poor people who can't afford the extra, who get stuck and are unable to get access to care. So you've got to include the air ambulances and things like that to cover rural and poverty areas.
Right.
Eddie, do you have a question? Betty Keller? I see you're active in the chat. Trying to monitor where we are. Betty Keller, do you want to unmute?
Pardon me?
did you have a question or are you just commenting, Betty?
I was commenting.
Oh, okay. Okay. Steve, do you want to just kind of put a wrap on this and just to recommend next steps for people, for folks? Like, what is it that concretely we should be doing in our own communities, in our own states, and even focusing some firepower at the national level to get support for our localities? What is it that you would recommend we do just from a practical standpoint, educating, motivating, activating?
I think that what we should be doing when we talk to hospitals is to explain the difference between CMS idea of budgeting and what we have in mind as budgeting, because they're not the same. And that what we have in mind would make their budgeting process much simpler, much more secure, much more predictable, and would protect them from the kind of uncertainty and problems that they're now dealing with. And it would relieve them of the responsibility to do billing and collections and the cost of doing billing and collections, because their budget would be set up front. And if we can get the hospitals to start clamoring for this, that would help a lot. I would like to do something similar with physician payment, and I have a proposal for that, which is on the OPS website, and another version of it is pending publication now. It's out for review. And if we can get that in place, I would like to approach physician groups with that and say, if we had this, would this be better than what you're dealing with now? Which I think they would agree it is. And then use that as an organizing tool among doctors, same thing with nurses, same thing with hospitals.
Terrific.
But it's important in talking to hospitals that they know the difference between what CMS is doing and what we're proposing. They're not the same.
Excellent.
One comment
Thanks.
about different hospital CEOs is if you're a small hospital CEO, you're worried about survival. So you like the idea of capitation. If you're a big hospital CEO, you want to build empires and you're making a ton of money and you're not sure you like capitation. So you may have to go around the CEO and try to get to the board of the hospital who has a mission to provide care. So just a little advice on when you approach hospital CEOs.
Okay. Rich?
Yes, earlier, Steve, you mentioned to avoid underfunding, you allow, I think you were saying the doctors, nurses, and hospitals administrators to be negotiating with the single payer or the state. Is that happening at all now? Say, for example, in Medicare, is there a current example we could point to that sort of successfully finds what a fair price is?
This is how they do it with physicians in Canada, where the physicians are all required to join the Canadian Medical Association, which is empowered to negotiate fees with the government. And they have those negotiations on a regular basis, and they get their fees adjusted when it gets out of whack. So that's the best example. In the US, Medicare sets fees unilaterally. All the insurance companies set fees unilaterally. They're all jockeying for position against each other, and it's a mess.
Okay, but just a caution also, having spent 2 weeks in Canada this year, visiting all my cousins, there's a great debate going on about a need for some significant change in the Canadian system. And part of that is due to underfunding, lack of primary care physicians, and not paying them well enough. Stephen, any response to that?
As of a few years ago, Canadian physicians were reasonably happy with the way they're being paid. And I know that historically, Canadian physicians have tended to lose ground with pay until there's a problem with recruiting doctors for rural areas, things like that. And then there's a hue and cry, and they get some leverage in negotiations, and they correct things, and it's better for a while, and then it drifts down. So there's a cycle that's happening in Canada, and they may be at the low point of that cycle right now. But over the long haul, that process has worked better than any other system I know of. It's not perfect, but I don't know of anything that works better than that. Doctors in other places in single payer systems like Taiwan or Japan are severely underpaid, and they have to make up the difference by selling drugs out of their office, the pharmaceuticals out of their office, or other ways of making money on the side. Otherwise, it's not worth it to be a doctor. But you need some way to make sure that the pay for all providers is proportional to the cost of doing what they do, including the cost of medical training.
Okay. Steve, I popped your email address in the chat here, right?
Okay.
Stephen@kemble@gmail.com.
Yep.
Okay, so that's how folks can reach Steve. Mike will be sending around the, I guess, the recording and the slides. And Mike, Steve just gave you some great talking points for your meeting.
Yeah.
David Loud, David.
Yes, last I knew, I'm up in Washington State. In British Columbia, in addition to the physicians negotiating their fees with the provincial plan, the hospital workers union, which I think was pretty much an all category union for the non-physicians, in other words, RNs and the rest of the workforce, also negotiated with the province. Is that still the case, do you know? And that certainly would be an important model for a number of our states where hospital workers are well organized.
I don't know any more about it than that, what's going on in Canada, but I think the more that employee groups can negotiate collectively, the easier the budgeting process becomes, because everything is set.
Thank you.
Okay. Well, just want to give another a great applause for your work, Steve. Your leadership, your thinking on this. Mike, and folks, maybe link and take a look at the One Pair States website if you don't have it, or if it's not at the top of your queue, onepairstates.org, and then link over to resources, and you'll find the policy work group papers. And it's just a treasure trove of resources for your work. And please do consider supporting the work that we do at One Pair States financially, if possible. We have work groups that focus on policy, that focus on outreach, that focus on education, advocacy. We're always looking for new blood and new activism. So donate your time and or money is really, really critical to the work that we're doing. And we're reaching into new dimensions and building a winning strategy for not just healthcare justice, but justice for all. And that's really the rethink that we're going through, as we connect ourselves across all of these bands of social justice campaigns. We'll create the capacity and the power and the numbers. And if we see injustice for one as an injustice for all, suddenly your eyes flip wide open, and you see the connection and the politics that are going to bring the policy to fruition. So thank you all, everybody, for coming together. Look forward to seeing folks tomorrow at the Intergenerational Summit, 9 Pacific. And Mike, is your hand up?
Yeah, I just want to announce that Donald Cohen, author of The Privatization of Everything, will be on our next, office hours. And Betty, and if you're still on, I forget which time it was. It's in February, but keep an eye open for that. It clearly makes the case that it's not just in healthcare that this privatization is going on, and it does tell us how we can counter this wave of privatization. So Donald Cohen at our next office hours.
Mm-hmm.
That's March 14th.
March 14th. Okay. And also just to share that I'm going to be moving up to Seattle next week. I've been in Corvallis for the last couple months, working here closely with the folks in Oregon and Washington. I'm so excited just to share with you all that I'm learning and the great conversations coming in as an outsider, and then trying to find out ways that we can elevate ourselves even more. Also in conversation with folks in New York and California and elsewhere, But the larger context, larger picture here is like what Mike said, privatization of everything is one of the cornerstones of what is clearly, in my mind, as an historian as well as an activist, is fascism. It's state corporatism, it's white nationalism, it's religious nationalism. Those are the three cornerstones. And I have a website, it's called AmericanFascist.us, and that's why I blog over there. So I work on another track. And then we have a pro-democracy website called justiceforall.global. So pro-democracy, anti-fascism, healthcare, and health justice. We bring all that together, and I believe that's a strategy for winning. So thank everybody. Thanks everybody for being with us. Have a wonderful weekend. Look forward to seeing you tomorrow. I'll drop those other websites into the chat before, as on the way out. Thank you.